Welcome back to the deep dive. Today, we're taking a really focused look at mood disorders. Think major depressive disorder, bipolar, and importantly, suicide risk.
Yeah, our goal is to pull out the absolute clinical essentials, diagnostic criteria from the DSM-5, key treatments, basically what you need for a quick but solid understanding.
Exactly. Getting you informed fast.
And before we jump into conditions like depression or mania, we really have to clarify the basic language. The terms we use in assessment are fundamental.
Okay, good call. Because in everyday talk, we kind of throw around emotion, mood, affect, almost interchangeably, don't we?
We do, but clinically they're distinct. Think of it like this. Emotions are those quick, subjective feelings, your immediate reaction, internal, personal.
Right, like feeling happy for a moment or angry.
Precisely. Now, mood is different. It's more sustained. It's that pervasive emotional background hum. It's what the patient tells you they feel, their internal climate over time.
Okay, so mood is the longer-term internal state.
Yeah.
And affect then.
Affect is what we see. It's the observable behavior that shows the mood. Facial expressions, how someone carries themselves, their tone of voice. It's the external display.
Got it. Internal subjective feeling versus external objective observation. That clarity is crucial for assessment.
Absolutely. And it helps frame the continuum of response, too. From adaptive reactions like normal sadness or uncomplicated grief.
All the way to maladaptive responses, things like emotional suppression, maybe delayed grief, or ultimately these disorders like depression and mania.
Exactly. It's a spectrum.
So let's start with major depressive disorder, MDD. The impact is just staggering, something like 1 in 8 adults affected. And mood disorders are a top cause of disability globally.
It's huge. And here's that paradox the sources highlight, which is quite stark. 80 to 90% of people actually respond well to treatment.
Wow, 80 to 90%, that's really high.
It is. But so many never seek help. It tells you a lot about stigma, access, maybe lack of recognition. The barriers are often outside the clinic itself.
And looking at causes, it's clearly multifactorial. Biology, psychology, social environment, they all play a role. But one thing that jumped out at me from the sources was about psychosocial triggers.
Oh, yeah. What specifically?
This idea that exit events, losses, separations, feeling abandoned seem to hit harder, seem more linked to the onset of depression than entrance events.
That makes sense clinically. It really underlines that sense of loss, real or perceived, as a powerful trigger. And we definitely see risk factors clustering.
Like what?
Well, being female comes with about a 1.5 times higher hospitalization rate. Then there's low socioeconomic status, any history of abuse or childhood trauma, and having chronic medical conditions, COPD, diabetes, heart disease, that sort of thing. They all increase risk.
Okay, and the way depression actually looks, the clinical presentation, it's often not just sadness, is it?
Not at all. First off, especially with older adults, you always have to rule out organic causes like subtle brain changes. But the big one, often missed, especially maybe in primary care, somatic complaints.
The physical symptoms.
Yes. And this is where cultural or gender factors can influence things. Men, and children too, might present with physical issues instead of saying they feel down.
So things like chronic stomach problems, unexplained pain, maybe heart palpitations, or just feeling utterly exhausted, that deep fatigue.
Exactly. They bring the body issues forward, not necessarily emotional ones. But if you're assessing for MDD, there's one symptom that's almost universally present. The sources cited 97% of cases.
And that's anhedonia.
That's the one, that profound loss of interest or pleasure in pretty much everything that used to bring joy. It's a core feature.
So to actually diagnose major depressive disorder using the DSM-5,
Yeah.
what are the hard criteria?
Okay, you need 5 or more specific symptoms, and they have to be present during the 2-week period. Crucially, one of those 5 must be either 1, depressed mood, or 2, that anhedonia we just talked about.
5 or more for 2 weeks, with 1 being depressed mood or anhedonia, and the others.
They include things like significant changes in appetite or weight, changes in sleep patterns, either insomnia or hypersomnia, decreased energy or fatigue nearly every day.
Feelings of worthlessness or excessive guilt, trouble concentrating or making decisions, recurrent thoughts of death or suicide.
And importantly, that observable psychomotor agitation or retardation.
Can you say a bit more about that? Psychomotor agitation or retardation?
Sure. It's not just feeling fidgety or slow, it's a noticeable physical change. Retardation is a visible slowing down of thought, speech, and movement. Agitation is the opposite, purposeless movements, pacing, hand-wringing. It shows how the depression is physically impacting the person's whole system.
Okay, that makes sense. Now, what about persistent depressive disorder, PDD? Used to be called dysthymia. How's that different from MDD?
The key differences are chronicity and often severity. PDD is defined by having a depressed mood for most of the day, more days than not, for at least 2 years straight in adults.
Here.
Yeah, it's long term. The
Mm.
symptoms are often less intense than a full MDD episode, maybe not leading to hospitalization, but because it's so chronic, it really grinds down a person's functioning and self-esteem over time, like a constant low-level drain.
A chronic drain versus an acute episode. Got it. So, understanding MDD and PDD, let's talk about treatments, specifically pharmacology, starting with the first line options, SSRIs.
Right, the selective serotonin reuptake inhibitors.
Yeah.
Drugs like fluoxetine, sertraline.
Mhm.
They're generally the first choice now. They work by blocking the reuptake of serotonin, leaving more of it available in the brain synapses, generally safer than older meds.
And the absolute critical point for anyone starting these, you mentioned it earlier, but it bears repeating, they don't work instantly.
Cannot stress this enough. It takes time, often several weeks, maybe 4 to 6 weeks, or even longer, for the person to feel a real difference in their mood. Managing expectations around that delay is huge.
That wait time is tough, but there's also a serious immediate risk we need to cover, serotonin syndrome.
Yes, this is a potential medical emergency. It's caused by having too much serotonin activity, often from combining medications that boost serotonin, maybe even accidentally, like with certain supplements or cough medicines.
And it has a pretty distinct set of symptoms, right? A classic triad.
It does. The classic triad includes, first, altered mental status, think sudden agitation, confusion, disorientation. Second, autonomic instability, like rapid heart rate, high blood pressure, sweating, high fever.
Okay, mental status changes, autonomic system going haywire. What's the third?
Neuromuscular abnormalities.
Mm.
This includes things like tremors, muscle rigidity, twitching, and especially hyperreflexia, really exaggerated reflexes. Seeing that combination should ring alarm bells.
Confusion, racing heart, maybe fever, plus those muscle changes definitely sounds like an emergency.
It absolutely is. Needs immediate medical attention. And while SSRIs are first line, we should briefly mention the older antidepressants because they carry significant risks too.
Like the TCAs,
Ah,
tricyclics.
exactly. The big danger with TCAs is overdose potential. They can be fatal in overdoses, mainly due to cardiotoxicity and neurotoxicity, and this can happen quite quickly, much less forgiving than SSRIs.
And the MAOIs, monoamine oxidase inhibitors. They're used less often now, but what's the major risk there?
The headline risk with MAOIs is hypertensive crisis, a sudden, dangerous spike in blood pressure.
And that's linked to diet, isn't it?
Yes, very strictly. People on MAOIs must avoid foods high in tyramine. That includes things like aged cheeses, cured or smoked meats, certain beers and wines, fermented foods like sauerkraut. The interaction can be life-threatening.
Wow, okay. So strict diet is non-negotiable with MAOIs. Now let's shift to a very different kind of treatment. Electroconvulsive therapy, ECT, often sounds scary, but the sources frame it as highly effective for specific situations.
Extremely effective, actually, especially for severe recurrent depression, cases that haven't responded to multiple medications, or when there's intense suicidal ideation needing rapid intervention.
How does it actually work?
Well, it involves passing controlled electrical currents through the brain to intentionally trigger a brief generalized seizure. This process seems to cause changes in brain chemistry that can rapidly alleviate depressive symptoms.
Okay. And it's not just one session, right? It's a course of treatment.
Right. Usually requires a series of treatments, often 6 to 12 sessions, maybe 2 or 3 times a week. And the patient needs to be medically cleared for it. Involves anesthesia. It's a significant procedure.
What about side effects? That's often the main concern people have.
The most common and discussed side effects are temporary. Things like headache, muscle aches right after the procedure, and significantly, some short-term memory loss and confusion, particularly around the time of the treatments. Usually, this improves after the course is finished.
Is there anyone who absolutely cannot have ECT?
The main absolute contraindication is increased intracranial pressure, like from a brain tumor or recent stroke. That would make inducing a seizure extremely dangerous.
Okay, so from complex treatments like ECT back to basics, communication. The sources emphasize how important therapeutic communication is, but also how easy it is to get wrong.
So easy. The key is avoiding those conversational roadblocks, especially cliches, things like cheer up or look on the bright side or everyone feels down sometimes. They often invalidate the person's experience.
Right, they just shut down the conversation. So instead,
Offer genuine therapeutic hope. Acknowledge the difficulty, express that recovery is possible, even if it's slow. Frame depression as a treatable condition, a self-limiting process eventually, and emphasize support and patience.
That makes sense. Okay, let's switch gears now to the bipolar disorders. The key here seems to be understanding the difference based on the highs, the manic or hypomanic episodes.
Exactly. The core distinction between bipolar 1 and bipolar 2 lies in the intensity of those elevated mood states.
So, bipolar 1.
Bipolar 1 is defined by having experienced at least one full manic episode. We're talking about a distinct period of abnormally elevated, expansive, or irritable mood lasting at least a week, or any duration if hospitalization is needed. The impairment is severe, often requires hospital care for safety.
Okay, full mania, severe impairment, often hospitalization, and bipolar 2.
Bipolar 2 requires at least one hypomanic episode, A and D, at least one major depressive episode. Now, hypomania is less severe than full mania.
How less severe?
Well, it lasts at least 4 consecutive days. The mood change is noticeable to others, but it's not severe enough to cause major problems in work or social life, doesn't require hospitalization, and, crucially, never involves psychotic symptoms.
Wait, so even though bipolar 2 includes major depressive episodes, which can be really severe, the hypomanic part means no psychosis and no hospitalization ever for the mood elevation itself?
Correct. That's the defining line. The mania component dictates the I versus 2 diagnosis. Hypomania is clearly different from normal mood, but doesn't reach that level of functional collapse or psychosis seen in full mania, though, as you said, the depressive episodes in bipolar 2 can be just as bad, or sometimes even worse, than those in bipolar 1.
Interesting distinction. And then there's cyclothymic disorder.
Right, cyclothymia is like a milder, more chronic form. It involves numerous periods with hypomanic symptoms, but not full hypomania, and periods with depressive symptoms, but not full major depression, for at least 2 years. The ups and downs are persistent but don't meet the full criteria for bipolar 2 or MDD, still causes significant distress or impairment, though.
Okay. Looking back at that full manic episode criteria for bipolar 1, what are the key symptoms clinicians look for?
The DSM-5 lists several, things like inflated self-esteem or grandiosity, a significantly decreased need for sleep, maybe feeling rested after only 3 hours.
Being much more talkative than usual, feeling like thoughts are racing, easily distracted.
And this is a big one. Excessive involvement in activities that have a high potential for painful consequences.
Like what kind of activities?
Think unrestrained buying sprees, foolish business investments, sexual indiscretions, actions driven by the expansive mood and poor judgment that can cause serious harm later on. That's a major red flag during assessment.
So when someone is in a manic episode, what are the priority interventions? Safety seems paramount.
Absolutely. Safety first. The person might be agitated, impulsive, have poor judgment. So interventions need to be clear, simple, and consistent. Use short, concise explanations. Set firm limits on behavior.
And practically. What about basic needs?
Good point. People in mania are often too on the go to eat or drink properly. So
Right.
offering high-calorie, high-protein finger foods and drinks they can consume quickly while moving around is important. And encouraging rest periods, even if sleep is difficult, is vital to prevent physical exhaustion.
Makes sense. Keep it simple, keep them safe, meet basic needs. Now, for bipolar pharmacotherapy, the classic treatment is lithium, still considered first line.
It is, particularly for treating acute mania and preventing future episodes. It's very effective for many people. But
The but is the safety profile, right? That narrow therapeutic index.
exactly. This is probably the most critical thing to know about lithium. The difference between a therapeutic dose and a toxic dose is incredibly small. Requires very careful blood level monitoring.
What are those levels we need to know?
The target therapeutic range is generally narrow, around 0.6 to 1.0 MeUQL. Some sources might say up to 1.2, but keeping it tight is safer.
And what happens if it goes above that? When does it become toxic?
Toxicity usually starts to appear above 1.5 MeUQL. Early signs might include things like nausea, vomiting, diarrhea, thirst, polyuria, lethargy, slurred speech, and a fine hand tremor might become coarser.
And if it gets even higher, say above 2.0,
Then you're into severe toxicity. Symptoms can include ataxia, loss of coordination, blurred vision, seizures, severe low blood pressure, confusion leading to coma, and potentially death. It's very serious.
okay, so the monitoring has to be meticulous. What are the absolute must-know patient teaching points for someone on lithium? You mentioned sodium in fluids.
Yes, absolutely critical. Lithium is excreted by the kidneys, much like sodium. So anything that significantly changes the body's sodium or fluid balance can drastically affect lithium levels.
How so?
If someone gets dehydrated, say, From sweating heavily, vomiting, diarrhea, or just not drinking enough, the kidneys try to conserve water, and in doing so, they also hold on to lithium, causing levels to rise dangerously. Similarly, a sudden drop in sodium intake can cause lithium retention.
So consistent salt and fluid intake is key. What about other medications? Anything common to avoid?
The big one is NSAIDs, non-steroidal anti-inflammatory drugs. Think ibuprofen, naproxen. They can reduce kidney blood flow and decrease lithium excretion, potentially leading to toxic levels. Patients need to be explicitly warned about this. Regular Tylenol, acetaminophen, is usually safer.
Got it. Consistent sodium, consistent fluids, avoid NSAIDs unless cleared by the doctor. If lithium isn't an option or doesn't work,
Then clinicians often turn to certain anticonvulsant medications, which also act as mood stabilizers. Drugs like Valproate, Depakote, or lamotrigine, Lamictal, are common alternatives. Sometimes, second-generation antipsychotics are also used, either alone or with other mood stabilizers.
okay. Now, shifting to our final and perhaps most urgent topic, suicide risk and assessment. The statistics, especially the Canadian ones you mentioned, are really sobering.
They are around 4,500 adult suicides annually in Canada, suicide being the second leading cause of death for young people aged 15 to 34, and those stark disparities, 3 times higher rates in men compared to women, and 5 to 6 times higher among Indigenous youth. It's a crisis.
Those numbers really demand that we take assessment seriously. The SAT person's mnemonic is a common tool for this, right? Can we walk through it?
Yes, it's a helpful checklist, though not exhaustive. S is for IGNAC. Sex male gender historically carries higher risk of completed suicide. A is for age older adults and adolescents young adults are high-risk groups.
D is for depression, a major risk factor, present in a large percentage of suicides.
P is for previous attempts. This is one of the strongest predictors of future attempts. E is for ethanol or other substance use. R is for rational thinking loss, like psychosis or severe hopelessness.
Okay. S is for social supports lacking. O.
O is for organized plan. Does the person have a specific plan? How lethal is it? Do they have the means available? This needs direct questioning. N is for no spouse or significant relationship. And the final S is for sickness, chronic, or debilitating physical illness.
That mnemonic provides a good framework, but there's one specific point about timing and risk that seems counterintuitive but is critically important.
You're probably thinking about the period when someone seems to be coming out of a deep depression.
Exactly that. Why is that specific time so dangerous?
It's a period of heightened vigilance. When someone is profoundly depressed, they might have suicidal thoughts, but lack the physical energy or cognitive ability to act on them. As their mood starts to lift, maybe with treatment beginning to work, they regain some energy and motivation.
Which might be just enough energy to carry out a plan they formed earlier.
Precisely. So that initial recovery phase, paradoxically, can be a high-risk window. It requires close monitoring and shouldn't be mistaken for immediate safety.
That is such a vital insight. So, if risk is identified, the intervention needs to be immediate. What does that look like?
Swift action is key. Mobilizing support systems, family, friends, crisis teams, increasing the level of observation or supervision, removing access to lethal means medications, weapons, etc., and developing a concrete safety plan with the individual.
No waiting around, act decisively.
Absolutely. Time is critical.
Okay, let's try to pull this all together. We've covered the difference between MDD, those 5 symptoms for 2 weeks, and the chronic nature of PDD, lasting 2 years. We've clarified bipolar 4 with its full mania versus bipolar 2's hypomania plus depression.
We've stressed the life or death importance of managing lithium carefully, that narrow window, the risks with dehydration and NSAIDs, and we went through the SAD person's tool for suicide risk, highlighting that dangerous period when depression starts to lift.
So, thinking about how this all connects, knowing these clinical details like the strict rules for lithium or that post-depression danger zone, it really should change how we listen and talk to people, shouldn't it?
It absolutely should. It moves beyond just ticking symptom boxes. It helps you understand the lived experience behind the criteria, the profound anhedonia, the feelings of worthlessness, the desperate need for effective, safe treatment, and real hope.
Which brings me to a final thought for you, our listener. We talked about how somatic complaints often mask depression and how empty cliches fail people. Thinking about everything we've discussed, maybe the physical reality of psychomotor slowing or the potential chemical chaos of serotonin syndrome, what specific clinical detail that we covered today most fundamentally changes how you might approach offering genuine, informed, and cliche-free hope to someone who is struggling? Something to reflect on.